Welcome back to video number 3 of the Trauma Bay. Alright, so C is circulation. I'm not going to go through all of checking pulses and whatnot. I'm going to talk to you just kind of about some tips and tricks. So, the number one thing I found is that people forget to call out access. That is part of circulation. Does this person have access? What size and where are the locations? Now, sometimes they'll come in from the field and they'll have no IV access or unstable or minimal IV access for how sick the patient is, and you'll need to get IV access. So if the patient is laying down on the cart, because we're running traumas in this here small closet, the problem is that at this hospital, they like to use the butterfly needles to to draw labs off of them. They think it's convenient to do that at the same time that the other nurses are putting in IVs. I think that's not the greatest way to go on with it, because we need whoever's doing the blood draws out of the way so that we can move on with the rest of our survey and interventions. So what I propose is that if the person comes in and looks kind of relatively sick, you do want to get a regular IV access instead of messing around with the central line initially, because that can be done pretty much immediately. So if they get a large bore IV like 216s, which provides better flow than a triple lumen, what you want to do is to take one of these large syringes, like a 30cc syringe, and after the nurse gets the IV in, instead of having her run fluids through that and then somebody separately take the same arm and stick it for labs, take this 30cc syringe, draw off 30 cc's, and then hand that off to the nurse with one of these, which is a large blunt tip needle, so that they can then go and fill their vials of blood somewhere else out of your way, and you can move on with your survey. Other times you need to get a formal central line because of where the location of the injury is, or they have access but it's already small access, so you're not going to put another, a 14 in the AC when there's already a 22 there, so you need to do a central line. So we have the normal 2 varieties of central lines here. We have the Cordis flavors, which are these. This is a true Cordis. This is basically a Cordis with 2 side ports as well, but it's a large bore percutaneous central introducer sheath. So you have those, and then you have your traditional kit here, which has a triple lumen. And then it has all the stuff that you use, hat, gown, mask, all that sort of stuff for a truly sterile line. So lines, like chest tubes, come in 2 flavors. There's emergent, as in it could go in the next 10 minutes, and there's emergent, as in we need it in right fucking now. So if you have one of the former varieties, you can use the other kit and of course be sterile with everything. If you have a right fucking now line, then don't worry about sterility, just bust open the kit. Now remember, with any central line, you really only need 4 things. You need 1, the actual line itself. You need the wire, you need the finder needle, and you need the scalpel so that you can secure, so that you can make your nick and secure the line in and whatnot. Alright, so what I would advise is to take the few things that you need out of the kit and put the kit somewhere else so that you don't have uncontrolled sharps laying around the field and stuff just flying all over the place while you're doing compressions and whatnot. So once you have those and you get your line in, another important thing to remember about emergent lines is you don't have to flush these. The large bore introducer sheaths, you can just get them in. Once you get them in, obviously you aspirate back so you're not flushing air in, but you don't need to pre-flush these. You need to just start going to be able to get better access for the patients. Once you get a large bore kit in, you can use even larger syringe like this here, 60, to draw off blood. The problem with using a 60 on a regular vein is that it often has a tendency to collapse, and the resistance is so high it winds up being like slower than you'd think it would be. So once you get a large bore IV in, or a large bore introducer sheath rather, then you can use a 60, get enough blood and pass it off. You actually need to fill up all the tubes about 40 cc's of blood. So just kind of keep that number in mind. Alright, the very last thing for circulation is, or second to last thing, is this. This is an ED thoracotomy kit, but it is missing an essential piece of equipment. namely the fucking knife. I don't know why they have a goddamn ED thoracotomy kit without a fucking knife in it, but it happens. So remember that you need to carry one of these on you at all times, just in case you somehow need to do an ED thoracotomy. The rest of the stuff in there, the rib spreader, the cross clamp is in there and it's pretty good. And then the other thing is, should you get to the defibrillation point, you need to make sure that you have the internal paddles, because the defibrillator, as you can see here, comes with the external paddles, but if you have then obtained access to the thoracic cavity, you might as well use direct cardiac defibrillation. Alright, so that takes you through ABCs. I guess there's one more technical thing with ABCs. Is people with extremity injuries that you need to do ABIs or DBIs on. Don't forget to bring your setup here. This is a manual BP, and it works with the usual blood pressure cuff. And then you have your Doppler here. So this is generally somewhere near the trauma bay, but it's, for whatever reason, not actually in the trauma bay. The last thing with circulation is to make sure that you have a blood pressure cuff ready to go for all of your patients. So it comes in 3 varieties. There's the normal adult size, there's the small adult size here, and then there's the big adult size. So if you have help, like extra bodies in the trauma bay, especially med students or whatnot, my goal is to get the BP cuff on the patient as the ambulance is coming in, so i.e. before they even get to the trauma bay. And then once they get here, you hook them up to the monitor and then immediately cycle the cuff. For most traumas where you are moving through your ABCs like normal, instead of you're stuck on a problem or a B problem, the rate limiting step in running any trauma is getting a blood pressure so that we can roll the patient. Alright, so those are tips and tricks for getting through C.